Hello everyone. Today I shall discuss a very small pharmacokinetic topic, clearance. Now as we all know, there are four pharmacokinetics parameters and processes. Absorption, distribution, metabolism, excretion are processes. We can club metabolism and excretion as elimination. Each has its own parameter which is measurable: bioavailability, volume of distribution, half-life and of distribution, then clearance, that is the volume per unit time. Usually we take liters per hour. For bioavailability, the area under curve, Tmax, Cmax are useful. For plasma half-life, the concentration versus time curves are taken, and therefore these are the indicators or measures of the processes, and some of them are extremely useful clinically. For example, determining route of administration, loading dose, maintenance dose, and dosing rates. There is a relationship among these formula processes also, uh, as measured indicators. Half-life is uh, calculated by dividing volume of distribution and clearance times the inverse log 2, and therefore we can say if clearance is reduced, half-life is increased. So we can also say half-life is not an independent parameter and is dependent on volume of distribution and clearance. There is a linear relationship between the elimination rate and concentration of drug for first order kinetics, and the constant is clearance. Now the term clearance should be understood very clearly. It has been used for various purposes: FDA clearance, mucociliary clearance, parasitic clearance, viral clearance, pre-water clearance. Today I shall be discussing clearance over. Now, closely related terms are elimination and excretion. Elimination is the process of removal of the drug from circulation by metabolism and excretion. Excretion here indicates secretion as well. For many drugs, the elimination is proportional to the plasma concentration, as I told you earlier, and the efficiency of elimination is assessed by quantifying how fast the drug is cleared from the circulation, and that is called as clearance. The unit of elimination is milligram per minute. Clearance is the rate of elimination by all routes normalized to concentration of drug in a biological fluid where measurement is done, meaning thereby that uniformly stirred volume is there from which a portion is removed, and along with that portion of fluid, drug is removed. It is a measure of ability to eliminate and is expressed by volume of the plasma cleared of the drug per unit time. Excretion is the final removal of the drug, and this is usually done by organs such as kidney, lungs, hepatobiliary system, or gut. Many drugs are excreted in more than one. Now let us understand clearance. Situation 1. An underground tank of a house was filling and filled with muddy rainwater, and the mud was uniformly distributed. Motorized pump was used to get the muddy water out to a separate tanker. The motor ran for 5 hours. Volume of the muddy water collected after 5 hours was 1000 liters, and the amount of the mud in the tanker was found to be 2.4 kg. So the question 1 is, what volume of the mud water was expelled by pump in 1 hour? Answer is 200 liters per hour. And what was the quantity of mud in 1 liter? 2.4 grams per liter. What is the rate of removal of mud by motor? 8 grams per minute. Now these three are important. In another situation, in the nearby house also, muddy water accumulated in the underground tank, but there was an inefficient filter installed in the tank. The same motor was used to pump out muddy water to a tank. The motor ran for 5 hours here also. The amount of the mud was found to be 1.8 kilogram in the tanker and the volume was 1000 liters. Therefore, what volume of muddy water was expelled by the pump in 1 hour? 200 liters per hour. What was the quantity of mud found in the per liter? It was 1.8 gram. And what is the rate of removal of mud by motor? 6 gram per minute. So what is the inference? Volume of muddy water expelled is fixed irrespective of density or concentration of mud in water. Therefore, volume of the fluid cleared of a drug in a unit time is called as clearance. This constant volume contained variable amount of the mud expelled. The rate of removal of the mud depended on quantity of mud per unit volume and it increased with increasing mud density. So there is a really linear relationship as seen for many drugs. Now rethink, assuming motor to be liver. A more powerful motor could expel more water. Thus, the clearance depends on the efficiency of liver to metabolize and eliminate. If we use a second motor with different specifications, think kidney, it will expel additional volume of the muddy fluid and the total volume expelled will be additive. Therefore, total clearance is renal clearance plus non-renal clearance or hepatic clearance, renal clearance per clearance by other. So, clearance, elimination, excretion are easily understandable. Clearance is constant for first order kinetics and clearance is not constant for zero order kinetics. It declines with the increasing drug concentration because of saturation of the metabolizing capacity. Whereas elimination is constant. A constant amount is fixed amount is eliminated in unit time. These distinctions should be understood. Interpretation of clearance value should be kept in mind the following factors: drug endose, organ blood flow, and impact of age and disease of organ function, intrinsic function of the liver, and intrinsic clearance presents the intrinsic capacity of liver to eliminate a drug, which is unbound of course, in the absence of limitations imposed by blood flow. Age is an important factor, and age advances, there is a decline in renal function, we know. The hepatic function in infants less than 4 months is poor, so there is a low hepatic clearance and reduced phase 1 metabolism in liver. In elderly, age-related decline in hepatic clearance is seen for several number of drugs, including alprazolam, prazosin, warfarin, theophylline, ethanol, and isoniazid. Renal function declines with age. Estimated GFR decreases at a rate of 8 ml per minute per 1.73 meters square per decade. And amazingly, serum creatinine may be normal. Therefore, this point should be kept in mind. In hepatic drug clearance, the drugs may follow linear kinetics, and for these drugs, liver has sufficient metabolic capacity to metabolize a large number of drugs, and the elimination process is not saturable. Therefore, rate of elimination proportional to concentration. Clearance is constant over a wide range of concentrations found clinically. Area under curve can be used to calculate clearance. The second group is drugs following capacity limited kinetics or elimination. Saturable, mixed order, or non-linear are the other terms used. For drugs like aspirin, phenytoin, ethanol, clearance does not remain constant but varies depending on the concentration of the drug. The concentration of drug will keep on increasing if dosing frequency increase or doses are increased. Obviously, area under curve will also go on increasing and cannot be used to calculate. The third variety is blood flow dependent clearance, and few drugs are rapidly cleared during their first passage in the liver. Therefore, whatever the drug is presented through hepatic flow is metabolized. These drugs have a high extraction ratio, and amitriptyline, isoniazid, propranolol, labetalol, lidocaine, morphine are the drugs of this category. Now you can see the impact of blood flow on this aspect. In situation 1, the inflow of muddy water is limited by the size of the inflow hole in the tank. If the power of motor to expel muddy water is high, it will expel whatever muddy water comes from the inflow hole. Therefore, here limitation is the flow rather than extent of metabolism, because of high capacity of metabolism is there. Disease of liver and drugs used could induce changes in the hepatic blood flow, and therefore they will alter the drug clearance and oral bioavailability by changing the pre-systemic elimination. Here in this type, protein binding is also important for because only free unbound drug is cleared, and as the protein binding is saturable, if higher doses are given, free drug levels are high. Extraction ratio drugs are morphine, lidocaine, verapamil, propranolol, nitroglycerin, and low extraction ratio drugs are many, warfarin, phenytoin, and as I told you earlier, increase in the fraction of unbound drug will increase clearance, and a decrease in the unbound drug will decrease clearance for such. Intermediate extraction ratio, aspirin, quinidine, codeine, nortriptyline, and these drugs will show changes in the clearance with change in the blood flow as well as protein binding and metabolism. Hepatic drug clearance is calculated by formula blood flow times extraction ratio. Now, therefore, extraction ratio means ability to extract and metabolize, and the blood flow both affect the hepatic clearance. Renal clearance of the drug. There are three processes involved: filtration, secretion, and reabsorption. We all know. Now, measurement of unchanged drug concentration in urine in a given time provides a measure of renal clearance, and this is not available for hepatic. Renal clearance is of three types. There are drugs which are eliminated primarily by glomerular filtration and gentamicin. Therefore, their clearance approximates estimated GFR. Second type of drugs are those that undergo significant tubular secretion, and their renal clearance equals renal blood flow. And there are drugs that undergo tubular reabsorption. Lithium carbonate, its clearance equals the urine formation, 1 ml per minute. What are the clinical implications? In renal impairment, clearance of large number of drugs, particularly aminoglycoside, is reduced and it requires dose adjustments. In congestive heart failure, lidocaine loading dose and maintenance doses are reduced because there is a reduction in the volume of distribution and reduction in lidocaine hepatic clearance. As well, in heart failure, there is a reduced blood flow in the liver. In liver disease, the maintenance doses of drugs that are extensively metabolized are reduced as there is reduction in the hepatic blood flow. For example, propranolol. Simultaneously, we must also know propranolol also reduces the hepatic blood flow in portal hypertension. Therefore, it may alter the extraction. Clearance may be responsible for drug-drug interaction. Metoprolol, propranolol reduce lidocaine clearance. Warfarin clearance is altered by inducers and inhibitors of cytochrome enzymes involved in warfarin metabolism, 2C19, 3A4 and others. Antidiabetic drugs, NSAIDs, they all interact this way. Renal level drug interactions are well known. Probenecid reduces renal clearance of oseltamivir, and that is ampicillin and cephalexin, and this is by inhibition of the tubular secretion. Spironolactone reduces renal tubular secretion of digoxin. Metformin clearance is reduced by radiocontrast media. So, in summary, clearance is the volume of the fluid that is completely removed of the drug in a unit time. A drug A has volume of distribution of the 20 liter. If clearance is 20 ml per minute, that means 20 ml of the 20 liter is assumed to be cleared of the drug in 1 unit of that time. Clearance is a kinetic parameter expressed also in the terms of elimination rate that we have already discussed. Clearance includes distribution and elimination. Total clearance is sum total of hepatic and extrahepatic. Knowing the clearance of a drug is useful because its value is for a particular drug usually constant over a range of concentrations, first order kinetics. Understanding drug elimination kinetics and the concept of drug clearance is essential for designing effective dosage regimes and ensuring safe and optimal drug therapy. It allows the individualization of the doses for particular organ function and individuals. Now, homework for undergraduates is: how are kinetic parameters interrelated? Is plasma half-life an independent kinetic parameter? What is the main use of plasma half-life estimation clinically? And rewrite Concroft-Gault formula for creatine clearance in females. For PGs, what fluid will you take for estimation of levels of cyclosporin and tacrolimus? Is the fluid whole blood or plasma? Is there any drug whose plasma clearance exceeds hepatic blood flow? Can aminoglycosides be used to assess renal function, renal clearance? Is there any drug that exhibits saturable absorption kinetics? And last question, a formula that reasonably estimates glomerular filtration rate in obese. Thank you very much, and the answer you may find in the next episode of the Learning Pharmacology selected topic.